Well, good morning, everyone. Thanks for joining us here today. My name is Matt Arango, and I have the distinct pleasure of introducing and moderating this session this morning, titled Following the Trail of Blood, Utility of Circulating Tumor DNA Across the Cancer Continuum. Before we begin, I do have a couple of housekeeping reminders. First, to participate in the audience response questions, you can use your mobile device camera to scan the QR code that'll pop up on the poll slides. Click on the link that pops up and that'll bring you to an app called Slido. And you'll also see a tab for questions and answers in the Slido app that you can use to pose questions to our speakers this morning. Please do hold all questions until the end of the session. You can either use the microphones in the aisle, or if you prefer, you can type your questions into the Slido app. We will take microphone questions first. At the end of the session, please make sure to write down the unique CE session code in order to submit for CE credit in HOPA Learn. And in order to do that, you can see the conference program book or the HOPA meeting app for full instructions. Finally, for the sessions that you do miss, don't worry, you will be able to access them later on demand in HOPA Learn, and the full conference on-demand bundle is included with your registration and will automatically appear in your HOPA Learn account when it is released in May. And with those housekeeping items out of the way, it's my pleasure to introduce today's speakers, Dr. Amber Cipriani and Dr. Mark Zangardi. Dr. Cipriani is a clinical pharmacist specialized in oncology care and pharmacogenomics. She currently serves as the Precision Medicine Pharmacy Coordinator at the University of North Carolina Medical Center. And Dr. Zangardi is a pharmacy coordinator for oncology precision medicine at Ohio Health in Columbus, Ohio. He also serves as the residency program director for the PGY2 Oncology Pharmacy Residency Program at Ohio Health Riverside Methodist Hospital. I'll now hand it over to Dr. Cipriani and Dr. Zangardi.
All right, thank you very much, Dr. Arango. Thank you very much, everybody, for being here today. I'm glad you're here, and I'm looking forward to speaking with you all. Just a heads up, Amber and I are on the same team. This isn't a debate, so we're not going to be drawing any blood, but we're going to be talking about blood a lot today. So buckle up, we're ready to go. Here's our disclosures. Learning objectives, I'm not going to go through these in detail. Really, essentially, we're going to be talking about ctDNA testing in various different settings and going through some of the current data limitations and summarizing things at the end with some of our more emerging uses. Setting the stage here, just wanted to highlight some of the key terminology that we'll be going through today. So first thing first, circulating cell-free DNA or cfDNA. This is the DNA that can be found in the cell-free component of the blood, which is the plasma. This can also be subdivided into circulating tumor DNA, which is the fragmented DNA component of the cfDNA that's derived actually from the tumor itself. Next, liquid biopsy. This is kind of a broad term that many of you may be aware of, but the main scope of this is it's essentially just analyzing those circulating nucleic acids, such as our DNA and some other components, including tumor cells or exosomes. And we often will utilize this to do molecular profiling to help us guide treatment decisions. And there's different applications and types of liquid biopsies, which hopefully by the end of the session, you guys will be very knowledgeable about. This is just a quick image to look at, thinking about how the tumor DNA is making its way into the bloodstream. So this is showing a blood vessel and various different components that are in the blood. So showing also a tumor, which is kind of the green-looking cells that are attached to the blood vessel. But basically, when tumors are breaking down, going through apoptosis or necrosis, the nucleic acids can be shed into the bloodstream. And again, this can be captured by doing blood sampling and different techniques where we can remove the DNA from the plasma and then expose them to these different testing modalities that can help us with our treatment decisions. Moving forward, just a quick, easy ARS question for the group here. In an individual patient, can the amount of ctDNA fluctuate over time? Easy yes or no for us. And here's the QR code for us to use. Just give us about 20 to 30 seconds. Okay, see over 100 responses, so I'll take that as a good sign. All right, very good. Yes, it can fluctuate over time, and we'll talk about how that may happen. Some more background on ctDNA, as I already had mentioned, this is released in the bloodstream, follows various factors. ctDNA does have a short half-life, so this can be variable over time and can change because of different factors, including the actual tumor characteristics. So different types of cancers can have different shedding rates. The sites of tumor can also be important, where certain metastatic sites may be less likely to shed into the bloodstream, such as bone metastases or CNS metastases, and then the disease burden. Generally, we see a correlation between a lower disease burden having less likelihood of having ctDNA, higher disease burden having higher likelihood. Also, depending on the rate of proliferation and cell death, so this could be related to the cancer type, as well as to the treatments that our patients are receiving. The tumor microenvironment can have some factors that play into shedding and the rate of ctDNA into the blood, as well as inflammation and different inflammatory conditions can impact our ctDNA presence and fraction. Next, just highlighting some of the key applications of ctDNA in cancer care. We're going to delve into these in detail in our subsequent sections of the presentation, but really this can range from use in patients without cancer to patients with metastatic cancer. So cancer screening really intended to be used in patients that do not have known cancer. So this can be applied to being early cancer detection and can be complementary to standard screening. This is really kind of an emerging field, not something that's really super well established yet. And then our next section would be molecular or minimal residual disease, MRD. A couple of different uses for this. Our main two applications that I'll highlight here are using ctDNA testing after patients have undergone definitive treatment for early stage cancer. And then the other one would be ctDNA during treatment, especially for advanced metastatic cancers. Some of the benefits of doing this, or potential benefits, would be risk stratification, especially in patients that have early stage disease. We can use this potentially as a marker for determining if patients need additional therapy escalation, or can just go on to potentially observation and monitoring. And next would be ongoing treatment assessments of effectiveness. So in our patients that are undergoing treatment, we could potentially monitor ctDNA to determine if the treatment is effective or if patients are developing resistance, and could be a way of determining if patients are developing recurrence, which we'll talk much more about as well. And then probably the best or most well-established use of ctDNA in cancer care is going to be our genotyping or molecular profiling. This is really what's mostly referred to as our liquid biopsy. And these are using ctDNA-based assays to detect actionable genomic alterations. So this is going to be informing treatment decisions, identifying also mechanism of resistance, particularly in patients that are receiving targeted therapies that might be developing new genomic alterations that can lead to resistance and may help us determine treatment options. This can be used as a complementary type of testing to our tissue-based testing, and a nice way, or a nice benefit of this is it can account for heterogeneity, which I'll talk about here on our next slide. So there's various different types of heterogeneity when we think about cancer. So on the top, we're talking about spatial heterogeneity, where over time, the molecular profile, genomic alterations can change as the treatments are given, as the cancer evolves. And then also on the bottom part of this slide, we're looking at the differences between tissue-based tests and liquid biopsy and how this can account for different heterogeneity. So when we get a tumor biopsy or tumor specimen via surgery, you're just looking at one little piece of the tumor, and the tumor can have variable different genomic alterations across it. So you might just be getting a quick snapshot. It might not be reflective of the entire picture of the cancer. So by using liquid biopsy, we can account for our intra-tumor and inter-tumor heterogeneity, because theoretically, the tumor is going to be shedding ctDNA from its various metastatic sites. So it gets us a more full picture of the genomic landscape or molecular landscape of the cancer. Quickly, just wanted to talk about some of the molecular profiling assays for our liquid biopsies and what types of technologies are used. So testing methodologies can vary between these tests. That's a key point as we're looking at which tests are used for patients or being studied. Broadly, the technological methodology would be polymerase chain reaction based or PCR based. The scope of these is essentially just looking at usually a limited number of genomic alterations, either in one gene or within several genes. Historically, this was often used, especially if we think about our non-small cell lung cancer patients, looking for our kind of classical EGFR mutations, our exon 19 deletions, L858R, T790M. And more often nowadays, we're using our NGS, next generation sequencing-based assays, which within a single assay, we can identify multiple different genomic alteration types, including single nucleotide variants, insertions and deletions, copy number alterations, and then our structural variants like fusions and rearrangements. And they can also potentially give us broader information, that molecular information, including our microsatellite instability status and tumor mutational burden. And keeping in mind, there are many different commercial assays that are available. So again, you have to kind of look at the different limitations and benefits of each test when interpreting them. With that, I will pass it over to Amber to talk about some ctDNA testing in our advanced metastatic disease.
Awesome. Thanks for that. You might need to help me with time because we're going to have to back calculate on our time. Okay.
Sounds good.
Mark's maybe we will draw blood. He might punch me when it's time for me to stop. All right, thanks for having me. So Mark kind of discussed the different uses of ctDNA testing. We're gonna work our way backwards, probably from where you all have seen ctDNA testing used in practice in advanced metastatic disease, and then work our way backwards to more of what I would say are the controversial or areas lacking a lot of data. So this is just a figure kind of reviewing all of those different clinical applications. For this section, we're gonna talk specifically about using ctDNA for treatment selection, as well as treatment monitoring and treatment resistance testing in the advanced metastatic setting. So I'll start us off with a case. This is probably someone who you've seen before. Patient with metastatic lung cancer, does have a smoking history, or sorry, not metastatic, early stage lung cancer, stage 3B, who we get a tissue biopsy. That biopsy is sent for genetic testing. We wait 2 weeks for the results. We're really excited to see if this patient has a druggable mutation. And then the report comes back and says quantity not sufficient, meaning the tissue sample that we sent for testing did not give us any results. So super disappointing. So the question there is, what do you do next? Do you go in and get more tissue from the patient, which is really invasive, or can you use something else? And so this is where you've probably used liquid biopsies or seen ctDNA used. What's the data for actually doing that? And so in these patients where the tissue sample is not enough to do the genetic sequencing test, there is some evidence, anecdotally, probably more than what's published in the literature, that using a ctDNA test or a liquid biopsy is a way to get some genetic results from that patient in the absence of doing another biopsy. And so this is a relatively small cohort, but it is patients with lung cancer. This was in Spain, and they looked at 93 patients who their tissue sample failed genetic testing, and then they tested them using a ctDNA assay. In this case, the assay was the Guardant 360 assay. And in about 90% of those cases, they had detectable levels of ctDNA, so we could get some genetic results and see if those patients were eligible for targeted therapies. And in this particular sample, about 15% of the time, we did identify a druggable alteration, which is pretty consistent with what we would expect if we were doing tissue-based testing. So the next question we asked, so we do get results from these liquid biopsies, but do we get the same results, right? Can we trust the results that we get from a liquid biopsy? Are they as good as tissue-based testing? And so in the literature, you'll see published for each individual assay, they're gonna try to publish different results. This is an example of one of those. So this is an Asian cohort of patients with lung cancer who had blood samples taken within 4 weeks of their tissue biopsy, and they compared the results, tissue versus blood. Are they the same? I will just draw your attention to the fact that majority of these patients were stage 4. So Mark was talking about how when you think about ctDNA, you have to think about, is the tumor shedding? Is there enough ctDNA in the blood? These were advanced cases. And so in this cohort, again, just lung cancer patients, we saw about a 70 to 80% concordance rate. The bar graph on the left there is showing you, I'm calling it concordance. It's actually like the positive predictive agreement, if you like statistics, which I don't at 8 a.m. So I'm gonna call it concordance. And you can see there is a bar graph for DNA and RNA. So we didn't get into sort of the NGS methods, but when we do tissue-based testing, you can actually sequence both the DNA and you can sequence the RNA. When you do RNA sequence, you have better sensitivity to detect some of the rare fusion events that now are becoming more and more druggable. And so I do want to point out in this cohort, there was lower concordance, about 47% when you did RNA and compared it to the ctDNA testing. So you still might detect more fusions with RNA sequencing. The little hairball pie chart there in the bottom is actually showing you if patients did not have concordance, what were the reasons for that? And so, again, 70% concordance, that's the purple section in those circles. But there on the left, if we only saw a positive result in the tissue, why was that? And so you can see that for the majority of patients where we saw mutations in the tissue but not in the blood, the reason for that was just that there was no detection in the blood. There was a subset where no plasma was available, but what that's kind of showing us is that in this case, tissue-based testing was a little more sensitive. And it makes sense, right? Because if you're actually taking a chunk of the tumor out, you're gonna have more tumor DNA there to actually do the DNA sequencing on, versus with this circulating tumor DNA or cell-free DNA, you have quantitatively less. When we look at patients who had positive results only detected in the plasma but not in the tissue, the reasons there are in the yellow and orange bar graph. The majority of them were just tissue was not available. So that's our patient. The tissue QNS had failed. There was a subset, though, where they just didn't detect the mutation in the tissue. And so you're kind of like, well, why would that be? You just told me it was more sensitive. Well, in those cases, what you're probably seeing is that idea of tumor heterogeneity. So when you just look at one tissue sample from a single spot in the tumor, you didn't see a mutation, but it's actually there if you look globally at all the tumor cells there in the patient. And so that data was specifically in lung cancer. This is some data from another laboratory vendor, Tempus. And what I'm trying to convince you of here is that concordance looks to be pretty similar in other cancer types too. And so this was a bigger subset of patients, about 3,000 patients were screened with matched tissue testing and ctDNA testing. And in about 1,400 of them, they identified an actionable variant. And then the bar chart is showing you the concordance in different tumor types. So when you combine them all, the concordance was right about 70%, same as that LC Scrum study. If you look at the different diseases, lung, colorectal, and breast, there's a little bit of variation. Prostate looks lower, but I'll just draw your attention to the fact that there's only 40 patients screened in this cohort. So, okay, you get some concordance, about 70%, if you do blood-based testing and tissue-based testing. How do we know if we can trust the blood-based testing? And so Mark went over some terms at the beginning. These are some other terms I'm going to introduce you to help you figure out how do you evaluate the results that you're seeing on one of these ctDNA tests. And so some newer terms are ctDNA fraction, and what that's telling you is the total amount of ctDNA as a fraction of the cell-free DNA. How much is the tumor shedding compared to just normal DNA that your normal cell turnover is spilling into the blood? You can imagine the higher the ctDNA fraction, the better able we are to detect some of these druggable variants. We have better sensitivity. The other term you'll see on these reports is variant allele fraction. This is the frequency of the actual variant or mutation divided by the total reads, sequencing reads. It's giving you an idea of how prevalent is that mutant piece of DNA in the blood, okay? This can help you identify things like subclonal mutations, meaning maybe it's only a small tumor in the whole landscape of metastatic disease that has a mutation. That's gonna have a lower variant allele fraction compared to a mutation that's present in all the different tumor sites of the disease. When I'm thinking about giving a patient a drug, I'm gonna be more wanting to target a mutation that's present in all of the tumors when I'm thinking about treating metastatic disease. ctDNA burden is a slightly different calculation, but it's again looking at how much of DNA is the tumor spilling into the blood. And so how do we use some of these things to figure out, can we trust the blood-based testing? Or do I have to go back in that patient, that QNS, to get more tissue? And so this is that same study using the Tempus assay, same actionable cohort of about 1,400 patients. And what they looked at is on the y-axis there, you have positive percentage agreement, concordance, for those of us who have not drank enough coffee today, and ctDNA burden there on the bottom. And what you see is that the higher the ctDNA burden, the more tumor DNA in the blood, the more sensitive the blood-based testing. So when you get to greater than 10% ctDNA burden, you have about 95% concordance. And so you can use this ctDNA burden to figure out what is the sensitivity of the blood test, and is it sensitive enough, given the patient characteristics, that I can act on the blood test, or do I need to put the patient through another biopsy? This is showing you that data in a bar chart, and I'm showing it to you this way because I think it can help think about clinical decision making. So the bar chart that's labeled E is the proportion of patients who had unique variants, druggable variants, only identified on tissue and not on blood. And so when you look at those patients, the majority of unique variants were identified in patients who had a ctDNA burden of less than 0.5%. In those patients, you didn't have enough tumor DNA in the blood to detect a druggable mutation. And remember, druggable mutations are important because then the patient can, at least in lung cancer and other cancer types now, get targeted therapy, which can improve their overall survival, things like that. So you don't want to miss a druggable mutation. Conversely, in D, the bar chart is showing you the proportion of patients who we identified a unique variant by doing blood testing. We didn't find it in their tissue, we only found it in the blood. And in those patients, you see the ctDNA burden was greater than 10%. So these are the patients who probably had a higher burden of disease, lots of metastatic sites, tumor heterogeneity, like Mark discussed, and we needed a blood-based test because just sampling one tumor wasn't giving us the whole picture. So it's just kind of helping you figure out, when can you rely on one versus the other. So going back to the case, so this is a patient with earlier stage lung cancer, and so ideally we would have had results from tissue-based testing. In this case, I think you could order a liquid biopsy or a ctDNA test, but I would challenge you when you're reviewing the results to make sure you have enough of that ctDNA burden or fraction to know that you're having a sensitive enough test. If you don't, then it might be worth a discussion of getting another tissue sample to make sure that you're not missing a druggable variant here. So I've talked to you about concordance, but when can the blood-based testing or ctDNA testing maybe be misleading or difficult to interpret? And so this is another case that I really like talking about. It's one that came to our molecular tumor board, a patient with metastatic prostate cancer. They did tissue-based testing, which is the gold standard, and they didn't find anything. It was a dud. I hate when that comes back and it's like no actionable variants because I never believe it. I'm like, there's a mutation there, right? But they didn't find anything. So they ended up doing a ctDNA test in this patient. The sample was taken after he had completed docetaxel therapy. So keep that in the back of your mind. This patient had already gotten treatment. And these are the results. So they came back with an ATM pathogenic mutation with a variant allele fraction of 0.21%. The ctDNA fraction, which you know about now, was reported at 5%. So when can these results be misleading? So false negatives. So in this case, the patient had a negative result on tissue, but what do you do if you see nothing come back on one of these liquid biopsies? Can you trust that there's nothing there, or are you looking at a limitation of the test? Well, I already went through some of the data with that Tempus assay showing you that you can use the ctDNA fraction. This is similar data, but using a different laboratory vendor's assay. So this is a Foundation Medicine assay, and it's telling you a similar story, though. So the pie chart there on the left, where it says the liquid biopsy TF, which is the tumor fraction of less than 1%, what's saying there is that when they went back and did tissue-based testing in these patients, they found stuff. So for the Foundation assay, though, I want to draw your attention to their cutoff is 1%. So this is like the wild, wild west right now. I think of this as in pharmacy world when I'm trying to decide between a different PARP inhibitor or a different generic drug, they're not the same. So when someone says liquid biopsy, I want you to be thinking about which one, which test, what is the cutoff for this tumor fraction, because they're different based on the different tests. So as pharmacists, I don't think we're necessarily always thinking about that. We think about drugs in that way, but we're not thinking about these genetic tests in that way. You have to start doing that in order to accurately interpret the results. For this assay, again, when you look at patients who had a tumor fraction of greater than 1%, when they went back and tested the tissue, they didn't find anything. And so, again, this tumor fraction or tumor burden can help you figure out, can you trust these negative results? And then we're also concerned about the potential source for false positive results. So what if you do this super sensitive ctDNA test and you get a positive result, but it's not really there in the tumor? The major contributor to this risk is something called CHIP, which stands for clonal hematopoiesis of indeterminate potential. I practice in solid tumors, so I don't like to think about lymphocytes very often, but I have to when doing this. This is actually an artifact of clonal expansion of lymphocytes, which is normal. But what you can see is higher prevalence of what look like tumor-associated mutations, but they're not associated with the tumor. They're these pesky lymphocytes. And so this can contribute to false positive results. A lot of commercially available assays that you're ordering right now try to mitigate this risk by actually sequencing the lymphocytes from a normal sample or a blood sample they receive. I'm not gonna get into all that drama for you this morning. We haven't had enough coffee, and we'd probably need to do it over wine. But there are some common CHIP genes that I have listed here for you, and I'll draw your attention to two, ATM and CHEK2, which in some situations you're going to be thinking about to determine eligibility for certain treatments, like PARP inhibitors. And as we develop more targeted treatments, some of these listed here are targets. And so if you detect one of these, but it's not in the tumor, and you give the patient a drug, the drug's not going to work because it's not a tumor-associated mutation. So I'm going to throw you to the wolves and make you figure this out on your own with a response question. There's the case again, and I'm going to ask you for this patient with metastatic prostate cancer, would you consider a PARP inhibitor based on this ATM mutation that was detected on a ctDNA test with a variant allele fraction of 0.21% and a ctDNA fraction of 5%? Mark says I'm doing good on time. I can make some more bad jokes. Okay. They're more scared to answer my question than yours.
That's fair.
I should have done yes, no. Awesome, great, yeah. So I'm seeing a lot of people saying no because it could be related to CHIP. I might have led you to that response, but I think if we look at the variant allele fraction of that mutation, it's pretty low compared to the overall ctDNA burden. There's no tried and true cutoff in the literature. The one I use is anything less than 1%. I sit and think about, I pause for that extra few seconds to think about, could this be related to something else besides the tumor? The The other consideration in this particular patient is they'd gotten cytotoxic chemotherapy already. And when you think about the risk for CHIP, it actually increases after the patient's been exposed to DNA damaging agents. That makes sense, right? I've given you a drug to damage your DNA. I'm probably going to find some mutations that I caused by the drug there. And so again, you want to kind of pause. You can use ctDNA testing to determine eligibility for PARP inhibitors. What I'm trying to point out with this case, though, is you still have to interpret the ctDNA test. So just seeing the gene and a mutation on the report is not always enough to determine eligibility for treatment. So that extra pause to think about what you're seeing on the report. So I hopefully showed you data about the concordance between the two testings, but then I also showed you data that sometimes tissue-based testing is better and sometimes blood-based testing is better. So why don't you just do both of them together, right? Let's just make everybody's lives easier. We'll test everybody with both. Major barrier to this, obvious one, is cost. This is some data showing you what you actually get if you're gonna do concordant testing. This is that same cohort of patients from the Tempest data, and then the bar graph that's pulled out is showing you, oh gosh, I forgot we don't have a pointer. I missed my pointer. The lighter portion of the bar graph there is showing you that about 70% of the time you have concordance. The lighter blue is showing you that in 30% of these patients, you found something actionable on tissue only. So that's showing you that tissue is often more sensitive. The 5% at the top is showing you what you get if you add blood to tissue. So these are the patients where we found something in the blood that was actionable that wasn't in the tissue. So 5%, I'm like, okay, that's pretty good. But if you're thinking about this from a population health standpoint, you're actually looking at 27 positive results out of all of the 3,000 that were screened. So if you're looking at this from sort of a, do we screen everybody? That rate is a lot lower than 5%. However, I do want to remind you, if you look at the mutations that were identified in these patients, KRAS, EGFR, MET, for those 27 patients, you have to think about how you impacted their overall survival by finding those alterations. So I do think, thinking about this from the how many patients we need to screen is important, but when we're talking about precision medicine, we're trying to individualize care. And so we can't apply this whole, greater good, approach always when we're talking about an individualized care problem. So I don't have the right answer. I just always like to bring you back to those 27 people where we actually, found something that changed their whole trajectory. So I have on this slide, this is like the money slide when you're doing the test questions. Comparison of ctDNA versus tissue-based testing. So for tissue-based testing, you have an increased concentration of tumor DNA, so increased sensitivity often. Another benefit of tissue-based testing is it can be compared with other biomarker testing. You're going to be at presentations. I was just at one yesterday about antibody-drug conjugates where you have to do an ovarian folate receptor staining and HER2 receptor staining. You still need tissue for some of these other biomarker tests. They can't be done with ctDNA. Turnaround time for tissue-based testing tends to be a little bit longer, around 2 weeks. You have to get an invasive biopsy. Note, if you're needing to get tissue, try to avoid bone. In the lab, they have to decalcify the bone sample, and that can denature the DNA, so try not to use bone biopsies. And then the results are specific to the site of the biopsy, so you're not capturing heterogeneity. Blood-based testing, sensitivity depends on the ctDNA fraction. If you have a patient with early stage disease, if you have a patient with certain cancer types that don't shed, you might have limited sensitivity. Turnaround time is usually faster. It's non-invasive. A lot of vendors offer mobile phlebotomy, which can be a logistical nightmare, but can increase access for a lot of patients. The other thing I didn't talk about, I have there at the bottom, is that it's less sensitive to detect copy number variants. So the methods that we use to do the ctDNA test, again, not as sensitive, so you're not going to detect like HER2 amplification in the same way that you would on tissue. You also, most people are not doing RNA sequencing on liquid biopsies or circulating tumor nucleic acids. So in most cases, you need a tissue sample to do RNA sequencing, but that's changing quickly too. And then in the last few minutes, we're gonna talk about in the advanced metastatic setting, I think the role for ctDNA to identify druggable variants is pretty well established. What the literature is kind of developing a canon on is, can we actually use this to monitor patients for response to therapy and monitor them for the development of resistance? So I'm gonna show you some quick data. There's a whole bunch of little studies. There's not any big randomized, beautiful studies where you're gonna give me a standing ovation here. So I'm gonna give you an example of the trend that we're seeing in the literature. What's lacking, though, is I can tell you that ctDNA might be correlated with response, but it's kind of prognostic at this point. We don't know what to do. I don't know if I should switch their therapy before I see progression. I don't know what to do with a lot of these results. So just know that when the provider comes to you and asks you to start monitoring for this. So this is a retrospective cohort. This is a Danish study. I pulled it in because it had a couple different tumor types: colorectal, ovarian, and non-small cell lung cancer. Notably, so they were asking, does ctDNA fraction predict response to chemotherapy? The assay they used is entirely different than the other assays we just looked at. Totally different methods. They have fancy words in it like methylation and fragmentation that will make you cry. But what I want you to know is that the method of this test is different, and that's something you have to ask yourself when the provider's like, let's monitor ctDNA. You have to make sure the method of the test is reflective of what you're trying to do. I'll also draw your attention to, in this cohort, the first ctDNA evaluation occurred at different time points, 4, 12, and 8 weeks. It's all combined into one happy family. But what they did see is that in patients who had a ctDNA response, and in this study they had to clear the ctDNA, they saw higher response rates, 31% versus 13%. And when you looked at overall survival, patients who had a ctDNA response had a better overall survival. So they were responding, they were living longer, again, prognostic. Where the next step that the data needs to take us is, what do we do in those who don't have a ctDNA response? Can we switch them to something? What do we do for those individuals? But the idea is that hopefully we can start intervening earlier. This data looks like it's similar for immunotherapy, and it might be particularly valuable because we have a lot of situations where we don't know. Do we give them chemo plus IO? Do we give them IO alone first? And in this case, we might be able to use ctDNA to figure out, are they responding to our first attempt? And if they're not, we can change things more quickly. Again, no data to say what happens if you do change, but what the data does suggest is that patients who show a response via ctDNA have better prognosis, better overall survival outcomes. There's a ton of questions in this area, so I don't think ctDNA to monitor for response is ready for mainstream. We don't even know what the normal fluctuation is. You asked that question, we don't test people daily or weekly for ctDNA, so we don't know if it just fluctuates based on this weird water that we're drinking. We have no idea. We don't know how much reduction is needed to predict benefit. We don't know which assay to use. We don't know if it's cost effective. Lots of, I think, research you're gonna see upcoming. What I know you're gonna see is that this is gonna be incorporated into clinical trial design. It already is. There's a few early readouts of this, but you're gonna see it incorporated into clinical trials. And I want you to be questioning the tests that they use, the methods, all of those things. Lastly, resistance. So in lung cancer, we have been using ctDNA testing to identify mechanisms of resistance. But the question is, if we identify a mechanism of resistance and act on it, does that help the patient? And so there is, I love this study in breast cancer, also not my area of specialty, but this was the PATA-1 study in hormone receptor positive HER2 negative breast cancer, patients receiving an aromatase inhibitor in the first-line setting, and they monitored them using ctDNA to look for mutations in ESR1, which is a known resistance mechanism to aromatase inhibitors. And in this study, when they found rising ESR1 in these patients, they randomized them to continue on aromatase inhibitor, which is what we've been doing because we haven't been monitoring, or switch to fulvestrant, which is a SERD and has activity. And what they found in these patients is that when they switched them early, they had better PFS. So 11.9 months versus 5.7 months. There's some issues with the drugs they used and the methodology, but I think the take home here is that you're gonna start seeing ctDNA used to monitor for known resistance mechanisms and possibly switch therapy. So last ARS question, I think this one's easier. Based on current evidence, which of the following is an appropriate use of repeat ctDNA testing? Only use it as a clinical trial, at the time of progression to look for resistance, routinely use it to monitor for response to therapy, or there's no role for repeat ctDNA testing after you identify variants. I'm gonna push so we can see the responses. Yeah, I think you might find people that would argue with me on all of these answers, but in my opinion, I think one role, especially based on this PATA-1 study and in the breast cancer space, would be looking for druggable resistance mechanisms. So I think Mark and I are going to talk just briefly. I think we both use ctDNA testing to find druggable mutations, but I'm curious, is anyone using it to monitor for therapy response or look for resistance where you're at?
Okay, I think I'm on here. Okay, yes. Definitely ctDNA testing more so to identify those druggable genomic alterations in a lot of different scenarios. For our patients with lung cancer, I think we're using more of the concurrent testing as well. A couple of benefits: you get the test results back quicker from our ctDNA, so could get patients on treatment quicker, and then also just the complementary aspect of it. But outside of that, not a huge use of it in the monitoring setting right now. I think it's still kind of the wild, wild west, as you mentioned, but I'd be curious to learn more about your experience too.
Yeah, I think we're the same. I think we have a few cowboys that are trying to use it. I think the issue I run into is people want to use it, but they order the wrong test. So they order the test that's supposed to be set up to actually identify variants and not the one that's looking at molecular residual disease, which is what we're trying to do, and I think what Mark's going to talk about next.
All right, thank you so much. And we'll see if we have time for bad jokes, dad jokes. I've got both of those in spades. But now we're going to switch over, talk more about our early disease, or MRD. So MRD and our hematologic malignancies, our colleagues out there probably are looking down their noses at us, our solid tumors, like, what do you mean you don't use MRD testing? We've been doing that forever. So definitely newer in the solid tumor space. So we'll go over some of the newer details and studies that are out there. But to Amber's point about a lot of these different tests, they have different methodologies, different uses. So in our MRD assays for solid tumors in particular, we're thinking about using these for early disease detection. We expect the patients, if they don't have clinically occult disease, that we're going to have to detect the ctDNA at a very, very low level. So these tests need to have very high sensitivity. The main technologies that we think about for these assays are tumor agnostic and tumor informed. So as you may see in that name, tumor agnostic is going to basically be kind of an off-the-shelf panel. It has a fixed panel of genomic alterations that they're identifying, whereas the tumor informed, they're taking a tumor specimen, sequencing it, and creating a custom assay that we can use via blood detection over time. And then, as Amber mentioned, that gives us some headaches, some of these other different things that we're maybe not as familiar with from the methodology. They can incorporate other features, including methylation signatures and fragmentomics. This is still kind of, burgeoning field. The methylation patterns are different between cancerous conditions and normal conditions, so that can be a mechanism that's used. And then fragmentomics is something that's even different, where they're looking at fragment sizes of DNA, which again can be unique for cancer versus patients without cancer. This just kind of highlights, again, the tumor-informed versus agnostic approach. Towards the bottom, just some of the differences. And the tumor-informed is going to require that tumor specimen to create the personalized assay, so it does have a longer turnaround time for the initial test. It does not account for clonal evolution. So again, thinking about that clonal heterogeneity or spatial heterogeneity, if you're just looking at the tumor specimen, you have that kind of fixed mutations that you're looking at or genomic alterations, but it may be more sensitive and specific since it is creating a customized assay for a patient. Whereas our tumor agnostic assays, it's again off the shelf, so a little bit logistically more feasible. Shorter turnaround time for the initial test because they don't require that tumor sequencing aspect of the test. Can detect the clonal evolution, but maybe a lower cost because it doesn't require that customized assay. This I won't dig too much in, but for your reference, just again, some of the different characteristics of the tumor-informed versus the uninformed or agnostic. Again, the key things are going to be there's differences between the methodology, so again, know what you're looking at, and turnaround times are going to be a little bit different, but these tests generally have pretty high sensitivity and specificity, and there's various different commercial assays that are out there that have different features. Next, I'm going to be digging into some of the data in our solid tumors of using ctDNA-based MRD tests to predict recurrence, and then its association with survival in resectable cancers. So this is a systematic meta-analysis that looked at 80 different studies that were either prospective or randomized control trials between 2013 to September of 2023. All of these studies that were included in the meta-analysis had to have had prospective collection of blood specimens with the intention of classifying patients as either ctDNA positive or negative. They had to have had resectable cancers, but could have ranged from stage 1 to 4. And they classified these as positive or negative in patients after surgery or after adjuvant therapy if they received adjuvant therapy. Number of different outcomes is noted on the slide, different survival outcomes that we'll talk about here. This is just some of the baseline characteristics. Again, at the top, just want to highlight there's different detection technologies that were assessed. And then at the bottom, different cancers that were included. Mainly, these studies looked at patients that had colorectal cancer, non-small cell lung cancer, but you can see various other solid tumors, pancreatic cancer, esophageal, breast, gastric, bladder, ovarian, melanoma, and hepatocellular carcinoma. So the exciting part here, looking at the association of ctDNA positivity with recurrence. So what was seen kind of universally across these different studies that were included was that being ctDNA positive was associated with higher risk of recurrence. So basically showing that if we do have patients after surgery and or after adjuvant therapy, if we can detect ctDNA, that those patients are at higher risk for developing recurrence. You can see across the different tumor types, the overall hazard ratio varied from about 3.5 up to 25. But with the different studies, again, they have different sample sizes. The confidence intervals varied widely. But if you look at the bottom, the total, looking at all these different solid tumors, the hazard ratio for predicting recurrence for being ctDNA positive was about 7.5, so pretty high hazard ratio. And then similar findings for overall survival. So we can see, again, across these different solid tumors, ctDNA positivity after surgery and or adjuvant therapy was associated with a higher risk of recurrence relative to patients that were ctDNA negative. And again, looking again at the bottom there, the hazard ratio for overall survival in these different tumor types was about 5.5. Another interesting aspect that they looked at in this meta-analysis was if we look at ctDNA testing at multiple time points, does that improve our sensitivity for detecting these survival outcomes? So this is specifically for looking at recurrence, and this is in our overall solid tumor patient population. The graph might be a little challenging to look at, but really the take-home point here is that compared to just doing a single landmark time point, say 2 to 4 weeks after surgery, by doing longitudinal testing, the sensitivity goes up. So if you are negative just at one time point, you might become positive later. And then if we pick that up with longitudinal testing, that increases our strength of determining if patients are likely to recur. All right, buckle up here because I have a lot of data I'm going to go through in 2 studies. I'm going to highlight 2 of our colorectal studies from a tumor-informed assay first, and then our tumor-agnostic assay. Again, a lot of details. I'm going to try to highlight things as much as I can. I might flip through some of our figures pretty quickly, but you've got the slides. And if you have a long flight or a long layover and you really want to look into the studies, I encourage it. It's a treasure trove of data and analyses, so if you can nerd out with your colleagues here. First, I want to talk about the Galaxy study. So again, this is a tumor-informed assay. This is an observational arm of a larger prospective multi-center study called Circulate Japan. As you may expect, this was primarily done in Japan, and then they had some patients in Taiwan as well. The goal of this study was to monitor a ctDNA-based MRD assay, specifically in stage 2 through 4 or relapsed colorectal cancer in patients that had curative intent surgery. So this did have a pretty large patient population, over 2,000 patients that were included. Again, the aim was looking at the prognostic as well as the predictive value of the ctDNA detection after surgery, a number of different outcomes that are listed on the slide there that we'll talk about in the next couple of minutes. This is just looking at the larger Circulate Japan study. So the middle part is essentially the Galaxy study that we'll be highlighting, again, this observational analysis. There was specific other studies that patients could enroll in, including the Vega study or the Altair study, depending on their ctDNA status, but we're going to focus just on the observational Galaxy data. The MRD test that was used in this study was a tumor-informed again, so this was Signatera by company Signatera Incorporated. Again, this requires knowledge of the tumor. So they performed whole exome sequencing on tumor tissue that was either from the resection or biopsy, and then they created the patient-specific assay. So they looked at 16 different patient and tumor-specific somatic variants in the plasma, and what they defined ctDNA positivity as was a plasma sample with at least 2 of these tumor-specific variants detected at a certain threshold. So again, when we're looking at these studies, looking at the tests, they have different definitions, so it is kind of wild. But just looking at the Galaxy study, these are the definitions that were used. In terms of the time points that we're looking at, so they looked at the MRD window, which was essentially 2 to 10 weeks after surgery and before the start of any adjuvant therapy. That's kind of like the landmark analysis. And then they also looked in the surveillance window. So again, kind of that more longitudinal serial testing. So that was basically from last follow-up until last follow-up or clinical recurrence. And if patients received adjuvant chemotherapy, this basically started at the end of the MRD window, or if they received adjuvant chemotherapy, it would have been 4 weeks after completion of chemo. This schematic that I tried to put together here just showed kind of the time points where they collected the blood. So in the first, at week 4, week 12, 24, 36, 48, 72, and 96, this was intended to kind of line up with when patients would be getting imaging roughly every 6 months. It is standard practice in Japan. All right, the exciting part now, looking at the actual clinical outcomes here. So summarizing this pretty closely here at the MRD window, which was over 2,000 patients, ctDNA positivity was associated with an increased risk of recurrence or death, and this was consistent across the different pathological stages. Again, this included stage 1 through 4 and different clinical pathological risk factors that are well established for colorectal cancer. And this is the data here. So there were 336 patients that were ctDNA positive after surgery compared to over 1,700 that were ctDNA negative. We look at the recurrence rate. The hazard ratio for recurrence for ctDNA positive relative to negative was 12, so it was highly statistically significant. And then also you can see the death rates there as well. Patients that were ctDNA positive were much more likely to have to die, and patients that were ctDNA negative were much more likely to survive. Hazard ratio close to 10. This is just a better way of looking at it visually for me. You can see the huge separation of the curves here. For blue is ctDNA negative, red is ctDNA positive. Again, having ctDNA positivity at this MRD window after surgery was highly prognostic for disease-free survival and then for overall survival as well. And you can see the curves separating for overall survival roughly at about 6 months there. So definitely clear prognostic association for being MRD positive in these colorectal cancer patients after surgery. But they also did some other initial exciting and interesting analyses, again, looking in the surveillance window, so more of our longitudinal assessment. So again, ctDNA positivity was associated for increased risk of death and recurrence, and at multivariate analysis, this was actually the strongest prognostic factor for poor disease-free survival. Looking at the numbers again, so ctDNA positive for recurrence and death, hazard ratio for recurrence was 33.56, so very highly associated with risk of recurrence, and then also with death, hazard ratio of 19.51. For our visual people, again here, looking at the curves for disease-free survival in the surveillance window, again, if you're ctDNA negative, much less likely to recur compared to ctDNA positive. And then same thing was found really for survival. And again, this was separating closely, starting at about the 12 months and over time was separating further, again, just showing how strongly prognostic ctDNA positivity versus negativity is for survival in these patients. So we really established this as a clearly prognostic marker, but is it predictive? Can we do anything different if patients are ctDNA positive versus negative, or are we just doomed? Or, is it just something that we have to deal with? So they looked at the role of chemotherapy. So again, this is observational, so take that with a grain of salt, but looking at our high-risk stage 2 or stage 3 patients with colon cancer, where we don't really know necessarily if all patients are going to benefit from chemotherapy or not. If we look at ctDNA, can that help us determine if patients should get chemo or can just go on observation? And this is breaking down the MRD status of our patients that were ctDNA positive or in this patients that received chemotherapy or not. So stage 2 or 3 colon cancer. Looking at our patients that were ctDNA negative, about 85% of patients were ctDNA negative, and then breaking those down about 50-50 split of if they received adjuvant chemo or not. In our about 14% of patients that were MRD positive, we did see that there was a higher rate of receiving adjuvant chemotherapy, about a 75-25 split. But looking at if these patients benefited from chemotherapy or not, what we identified in this study was that in patients that were MRD positive, if they received chemotherapy, they had a lower rate of clinical recurrence. But in MRD negative patients, adjuvant chemotherapy did not seem to impact the rate of recurrence. So looking at the numbers here, clinical recurrence rate on the top part of this chart is showing our MRD patients that were positive. If they received adjuvant chemotherapy, their clinical recurrence rate was about 61%. If they did not receive adjuvant chemotherapy, that was all the way up to almost 96%, so a hazard ratio of 0.23. So it seems like adjuvant chemotherapy did have a role in reducing recurrence if you were MRD positive. On the other hand, MRD negative patients, you can see the breakdown of clinical recurrence of if they received adjuvant chemotherapy or not, really does not seem to be any different. So I think this is a really interesting finding from this study that may be really clinically relevant. If we have patients that are MRD negative, they might not need to receive adjuvant chemotherapy, and we might spare them all of the toxicity and challenges that come with receiving adjuvant chemotherapy. This is, again, just a visual depiction of the data, DFS here for our MRD positive patients. Again, high risk stage 2 or 3. Adjuvant chemotherapy seemed to improve disease-free survival in MRD positive, but in MRD negative really didn't seem to have any barrier, any impact on disease-free survival. They also looked at patients if they cleared ctDNA while on chemotherapy and receiving treatment. And the interesting part about this is if patients did clear ctDNA, they seem to do better. So it again shows the potential benefit of doing longitudinal testing. Patients that did not clear ctDNA seem to be really at high risk for developing a disease-free survival event. And that was similar to our overall survival. Again, if you're not clearing ctDNA, it's a poor marker. So it's something that we can potentially monitor over time to establish patients' risk. And hopefully, based on additional studies, may help us determine if we can modify their treatment, escalate treatment potentially, but still kind of an emerging aspect of this testing. So again, looking at ctDNA testing over time, they broke this down as well as if patients had sustained clearance, so meaning that over time they did not find any ctDNA positivity, was kind of the best prognostic marker. If you had no clearance at all, that was the worst, and in the middle, transient clearance, like if you cleared on one of the or several of the draws, but then was positive later, that was kind of intermediate for both disease-free and overall survival. Take-home point here, patients that remain ctDNA negative do the best. Patients that remain ctDNA positive do the worst. In the middle is if you have that transient effect. All right, so again, ton of data. Hopefully this highlights it all for you. And again, if you want to get more into the weeds, feel free to download this publication and read it on the flight. But the big point here is that MRD detection in resected colorectal cancer is a very strong prognostic marker for both disease-free and overall survival. And this has really outperformed all of our established clinical pathological risk factors. This can also potentially help inform our post-surgical treatment. So really in those ctDNA or MRD negative patients, they might not really need adjuvant chemotherapy, whereas if you're positive, those patients did derive benefit from adjuvant chemo. And then again, the clearance might be an indicator of response to treatment, and then longitudinally testing patients can give us more information about detecting that molecular recurrence and their survival. All right, take a deep breath. Now we're going to switch gears and go to our tumor agnostic study. So this was the Cosmos CRC 01 study. Kind of a similar patient population, a bit of a different design for the study, but this was again looking at our resected colorectal cancer patients, clinical stage 1 through 3 with planned surgical resection. A smaller study, so 342 patients were included. It was, again, an observational study, but they were looking at this tumor agnostic or plasma-only MRD assay. The assay that they used in this study was Guardant Reveal, and this used, again, these epigenomic features as well. They looked at methylation patterns, so again, just thinking about the different technological aspects of the tests that are used when we're interpreting them. Kind of similar in terms of when they drew the blood to do the MRD analyses, really tried to line it up with kind of when we're doing clinical visits in patients with colorectal cancer. So for the first year, they looked at doing the testing every 3 months, then years 2 through 5 was every 6-month testing. Primary endpoint for this study was looking at ctDNA positivity rate post-operatively with their longitudinal surveillance. So with this primary endpoint, they looked at having 2 post-operative samples that were positive and how that correlated with clinical outcomes. And then there were a number of different secondary outcomes, as you can see on the slide here, and we'll go through some of the important ones, in my opinion. Overall, about 12.5% of patients did remain ctDNA positive after completion of treatment. And another interesting factor was it was associated with certain clinical features of the cancer. So this might be something that you would expect. So having a higher T stage, having lymph node involvements, lymphovascular invasion was correlated with being ctDNA positive. So this did have a correlation with some of our established risk factors clinically. Looking at the recurrence rates, so post-operative ctDNA positivity, similar to the prior study, was associated with a higher rate of recurrence. So looking at the 24-month recurrence-free interval, for ctDNA negativity was going to be much better outcomes. So our 24-month recurrence-free interval was about 95% compared to about 41% for being positive, with a hazard ratio of close to 17. And here's the visual learner, again, looking at the difference in the curves here. The blue is going to be if you never had a ctDNA positive result versus the goldish color is going to be if you had a positive result. You're much more likely to recur if you have a positive result with the ctDNA. They also looked at the landmark analysis, so really that single time point after surgery at 28 days, which kind of can correlate with when we're trying to determine treatment options for these patients. And they looked specifically in patients that had stage 2 or higher colorectal cancer, again, those patients that were generally considering adjuvant chemotherapy. Again, it was associated with higher risk of recurrence if you were ctDNA positive at that time point. The strongest predictor of recurrence, again, outperformed all of our established risk factors. So on the panel B here is again showing our recurrence-free interval. The blue is going to be positive ctDNA, and the goldish is going to be negative. And then this figure is showing us our other risk factors that we generally keep into consideration when selecting adjuvant treatment options. At the top, we see our ctDNA detection with a hazard ratio of over 5 being associated, again, with that risk of recurrence, overperforming or outperforming other factors like the higher T stage, lymph node involvement, and other features that they looked at. One thing that I did just want to highlight when interpreting the results of these tests is that the sensitivity can vary depending on the sites of metastatic disease that will develop for recurrence. So the sensitivity of this test was much higher in patients that had liver metastases compared to lung or peritoneal only. Going back to what we were talking about before, shedding rates can differ depending on where the tumor is located. So with liver metastases, it seems to have higher shedding rates, so the test might be more sensitive to detect recurrence in that setting, whereas lung tumors might not shed as high, and peritoneal only is maybe circumventing the vascular system just by having direct seeding from the colon to the peritoneum. So test was much higher sensitivity if they developed liver mets versus lung or peritoneal. I'm going to fly through these couple of slides here. Again, this is just hammering home the points. Really, being positive at all the different time points that they evaluated was associated with a higher risk of recurrence at all these different time points. So I'm just going to flip through them, but they're for your reference. And then finally, they did just look at the impact of ctDNA positivity after adjuvant chemotherapy in this study as well. Numbers are much lower than the prior study, and again, this is just observational, but what they did identify was that patients that were ctDNA positive after adjuvant chemotherapy had a shorter recurrence-free interval, so we're at higher risk for recurrence. You can see the median listed there, about 15 months for ctDNA positive patients versus not reached if you're ctDNA negative, for a hazard ratio of about 11.5. And then we've got the visual to look at there that really started separating at about 6 months. Again, similar to the prior study, if patients cleared ctDNA, they were having better outcomes. So that's at the top, kind of purple line. Patients that received chemotherapy, cleared ctDNA, had a much longer recurrence-free interval. Similar to the prior study, if you remained positive throughout treatment, had much worse outcomes. If you had that transient clearance, you're kind of in between. All right, so my overall summary for us here. Again, MRD detection via ctDNA analysis predicted recurrence in our stage 2 or higher colorectal cancer. Again, they looked at this at various different time points, and it was consistent across time points as well as after adjuvant chemotherapy. What they did find that was by doing longitudinal testing, that increased the sensitivity. So at 81% when we looked specifically at stage 2 or higher colon cancer by doing longitudinal sensitivity, but it did differ again based on the site of recurrence and as well as looking at rectal versus colon, which I didn't really highlight much, but the sensitivity was higher for colon primary versus rectal. That was thought to be based on the metastatic patterns as well. Rectal cancers are more likely to metastasize to the lung, so it could have just been an artifact of just the metastatic recurrence patterns for colon versus rectal. And they did note that the overall performance seemed to be similar to our tumor-informed assays, but I will take that again with a caveat of none of these assays are really being studied head-to-head. But they did note that MRD testing may support our adjuvant treatment decision-making, but that's kind of the next step of looking at the predictive value of these tests. All right, to wrap things up for this section, I've got an ARS question, a bit lengthy here, but I'll read off the question and then you can take a look at the response options. So which of the following is true regarding ctDNA MRD testing in resectable colorectal cancer in Galaxy? So that was our tumor-informed assay, and then as well as our Cosmos CRC, which was our tumor agnostic or plasma-only assay. Try to give a little bit more time since a lot of reading here. All right, let's do this together as we read through each option. So with tumor-informed testing, MRD positive patients derive benefit from adjuvant chemo, having a lower recurrence rate, whereas MRD negative patients did not derive benefit. I would agree that was seen definitely in this tumor-informed study, much higher benefits, if you will, by giving adjuvant chemo if you're MRD positive. MRD negative patients really didn't seem to have much benefit from adjuvant chemo, and we may be able to forego adjuvant chemo if you're MRD negative. The next option, compared to consistent or sustained ctDNA negativity, clearance following treatment was not associated with better outcomes. That would be incorrect. If you cleared ctDNA with treatment, that seemed to be associated with better outcomes compared to either sustained positivity or transient clearance. Longitudinal testing did not provide prognostic value. That'd be incorrect as well. By doing longitudinal testing, that improved the sensitivity of tests. And then finally, MRD testing prior to surgery can inform treatment decisions. That wouldn't really make sense because they would still have the tumor. So we're looking at testing after surgery in our resected patients for this use case. All right, and then before we transition to the next section, just wanted to do a quick discussion here with my colleague Amber. Just, do we feel like MRD testing is ready for prime time based on this data? What are you seeing in practice? Do you think it's ready for us to be doing for all these patients in colon cancer or other uses?
Yeah, I think we do have providers who are trying to order this test. I think colorectal cancer is the place we're seeing it most often. Mark and I have discussed there's actually some data in bladder, some emerging data coming out in breast and lung as well. The challenge is, again, what test do you order? So, you know, the two studies you presented use different tests. I think there's a lot of vendors saying, here's a MRD test and you can use it for any tumor type, but I don't know, what's the data behind that? And then the other thing is, what do you do? So I had a lung provider who was ordering this testing and a patient who kind of begged her to order it, and the results came back that she was MRD positive, but then we didn't know what to do, and it just kind of creates a sad situation. So I think we need a little more information about what to do in these patients who are MRD positive, and you know how to improve their prognosis with therapeutic intervention.
Yeah, I definitely agree. I'm seeing some uses in certain cases, but I don't think it's ready for broad adoption yet. I think it's clearly prognostic, but we need to know if it's predictive. Can we actually make a difference if we know patients are MRD positive versus negative? I think that's really a big next step that we need to establish. All right, kick it back over to Amber here.
All right, so we're almost done. I think in the last maybe 5 minutes or so, we just wanted to touch on the possible utility of using these ctDNA tests for cancer screening. And so this is another area, I think, where there's not a great canon of literature. It's fast moving, developing, but we wanted to kind of share with you some of those use cases. So ctDNA for cancer screening, it would be a blood test, so it seems pretty ideal. It's non-invasive. Patients don't have to get a colonoscopy, a mammogram, some of these invasive tests. There are concerns for false positives, so we talked about that risk of CHIP, and also concerns for false negatives. So when Mark was going through these MRD assays, when you have a patient who has early stage cancer, which is ideally what we'd want to find when we're doing cancer screening, you have to have a very sensitive test to detect these tumor-associated mutations. And so, the concern for false negatives when we're talking about, cancer screening is real. And then cost and feasibility. So, do you need whole genome or whole exome sequencing? How big of an assay do you need? Does it need to be tumor informed? And so are you only going to look for, for example, KRAS mutations to find pancreatic cancer? And that would limit the sensitivity of your test. Cost, how often are you going to test people, right? Are you going to do it monthly, weekly? We don't know. We don't even know how ctDNA fluctuates during that time. So lots of things to figure out. There is actually a ctDNA cancer screening test that's already FDA approved. It was approved earlier, or late 2024. I don't know what year it is. It's a little bit different in that it utilizes not just the DNA sequencing that I was talking about in advanced metastatic disease, but relies a lot on some of the methylation, so the epigenetic factors that are somewhat incorporated into the molecular residual disease assays, some of them. It also looks at DNA fragmentation patterns, which we didn't talk about, but when you have tumor cells undergoing apoptosis or spilling their contents into the blood, the way the DNA is chopped up actually looks different compared to how the normal cells spill their chopped up DNA in the blood. And so these assays are a little more sophisticated in an effort to increase that sensitivity. So for this Guardant Shield assay, again, specific to colorectal cancer, the study that garnered its FDA approval was this ECLIPSE study. It was a prospective observational study looking at detecting asymptomatic colorectal cancer. I'll just draw your attention to the fact that they excluded those, who would be at high risk for colorectal cancer. Those patients should have gotten more conventional screening methodologies. They looked at 10,000 patients to include. Ultimately, about 8,000 were evaluated. And I have in the red box there, just drawing your attention to about 300 patients out of the 10,000 that were screened had an invalid blood test. And so there is, again, issues. We saw that patient with the QNS result on tumor tissue. That's something to consider. It's not a slam dunk all the time. This is the sensitivity and specificity, and I realize it's like 8 a.m., and we've said those terms about 50 billion times, so I'm sorry, it's too early for those words. But this looking at the sensitivity and specificity of the Guardant Shield assay for colorectal cancer screening. And so you can see the comparison of most advanced findings on colonoscopy compared to the cell-free DNA test. And you can see the sensitivity when looking at colorectal cancer was pretty high. So between 80 for any stage, and it was higher for early stage disease. So it was really sensitive to detect early stage colorectal cancer. It was not sensitive in detecting precancerous lesions, and that was intentional. So anyone who lived through the era of PSA testing, where patients who came in with elevated PSA, we caused all this anxiety. They underwent biopsies thinking they had prostate cancer. This was actually intentional with the assay to make it specific for those who actually had colorectal cancer. So could be a good thing, depending on how you look at it. And then down below, the specificity was also relatively high, not 100%. This next slide is kind of giving you a theoretical of if we used this ctDNA assay rather than colonoscopy, which they're kind of using as the gold standard, how many patients would we identify if we screened 100,000 patients? With a colonoscopy, we'd have about 420 with a colorectal cancer finding. If we use the ctDNA test, we'd have 349. So we'd miss a certain subset, and that's what you're giving up. That's what you're looking at with the sensitivity and specificity. But overall, does a pretty good job. And I think the thing to think about here is that patients are probably more likely to perhaps get this blood test done compared to a colonoscopy. What's missing here from a cancer screening perspective is any sort of outcomes associated with doing the screening. So the test is approved because it's sensitive and specific, but what we don't know is how it compares as far as survival and I think more meaningful clinical outcomes compared to standard practice. So that data is not yet reported out. And then we've also been looking at these multi-cancer early detection tests. These are trying to look at not just colorectal cancer, but trying to use ctDNA to see if you have any cancer. And just suffice it to say that it's been challenging. There's been companies that have, I think, gotten close to doing this, but some of the challenges, are still there. We don't really have any outcomes. My question is, if you have a positive result on one of these tests, how do you work up the patient? Do you get a CT scan? How do you figure out what type of cancer they actually have? So lots of things to work out. So last audience response, which of the following characteristics are most important to you if you are gonna use a ctDNA blood-based cancer screening test? Do you wanna minimize false positives because you don't like to cause anxiety, minimize false negatives because you don't want patients to think they don't have cancer when they do, early stage versus late stage, you want to screen everything in an all-in-one test or do a few tests. So there's no right answer. I think this is kind of a polling question, but this is why looking at the studies, evaluating sensitivity, specificity are important when you're interpreting these results. So the moment you've all been waiting for, the CE code. You made it. So our summary here, I think tissue-based testing remains the gold standard for genetic testing, but ctDNA really has an evolving role, and I think it's pretty standard as an alternative or to be used concurrent in advanced disease. The data for monitoring response and resistance is evolving. I think these MRD assays are going to become really important in the near future. You're going to see a lot published on that. And then I also think it's going to be leveraged to develop early detection assays, but I think that's going to kind of come later. The take home I'll leave you is just pause and ask some questions about the methodology behind the testing. We didn't want to get into all that nitty-gritty, but it is really so important to make sure that the test that was ordered was appropriate and you're applying the results based on what the literature is kind of sharing. And I think at this point we have a few seconds maybe for hard questions.
Hi, Laura from MD Anderson. The obvious question, coverage, payment. I know people want to order them and they're FDA approved. So what have you guys been seeing around that? I know prior approvals, I'm sure, are required in 100% of cases, but what are you guys seeing with insurance?
I would say we generally lean on the companies to help us, with coverage, doing the approvals, as well as most of these companies have patient assistance programs that we try to get them on. I will say CMS may have coverage determinations for these tests. For commercial, it's probably not going to be covered a lot of times, but definitely utilizing their patient assistance. And if it's something that's more in the gold standard, the ctDNA, more liquid biopsy for detecting genomic alterations, I think is much more well established. When it comes to MRD and early detection tests, probably much less coverage that's available.
Thank you.
Hey, Beth Gustafson from St. Luke's Cancer Institute in Kansas City. One quick question. I know you guys work on molecular tumor boards. How do you incorporate these MRD assays into your patient tumor board workups? That's kind of been a source of contention for us because we're not always paying attention to like the Signatera results when we're looking at workups. So how do you as a pharmacist kind of monitor and follow these?
I'll say for us, our molecular tumor board, we haven't done a lot with the MRD assays. I think where we're kind of getting pulled in is from a programmatic standpoint, is advising providers on which test to order, when is it appropriate, and trying to come up with an approach, a standard approach. Most of the patients we're seeing in our molecular tumor board are those advanced metastatic patients. We haven't gotten very many consults yet on MRD, but I think it's, you don't know what you don't know, so we're trying to approach it from a programmatic standpoint and educate, provide information on how to utilize the test. I don't know if you've seen it.
Yeah, pretty much the same experience for me. We're mostly molecular tumor board. We're looking at our advanced metastatic patients for treatment decision making. We haven't really delved too deep into the MRD world yet.
Okay, thanks.
Thank you.
Thanks, everyone.
Thank you.